Good morning, everyone. I'm Janice Jones, Executive Director at the Public Justice Center. Just want to welcome everyone to Justice for Breakfast, our ongoing series of hot topics here at the PJC and with our partners. Today, we're going to have a conversation about patients over profits, ending the medical debt crisis in Maryland, with PJC's health and benefits equity folks and folks from the Debt Collective. So I just want to say welcome and thank you for joining us, to our friends, partners, collaborators, board members, stakeholders, and everyone else. So our process this morning is that we're going to have a presentation and a lot of good information from really, I think, the experts in this space, this emerging issue here in Maryland. We're going to have a lot of information, a deep presentation, and then opportunity at the end of the presentation for Q&A. And so with that, I'm going to turn it over to Ashley Black, who is our lead attorney on our Health and Benefits Equity Project. And again, good morning and thanks for joining us.
Great. Thank you, Janice. And thank you, everybody, for joining us. I see a lot of familiar faces in the audience, both some of my colleagues from PJC, but also many of our partners on medical debt over the years. So thank you. I'm so happy to have all of us in this space together. So as Janice said, my name is Ashley Black. I lead PJC's Health and Benefits Equity Project, which advocates to protect and expand access to healthcare and safety net services for Marylanders struggling to make ends meet. Before I get into what we'll be discussing today and lay out sort of what we'll be talking about, I just want to give my partners who we're working with on this presentation an opportunity to introduce themselves. So that said, I'll first pass things to David, and then Lindsey, and then Sam.
Good morning, everybody. I'm David Reische. I'm a paralegal with the Health and Benefits Equity Project and a former community organizer.
Good morning, everyone. Really, really wonderful to see so many familiar faces, as Ashley just said. My name is Lindsey Muniak. I lead the work on medical debt with an organization called the Debt Collective. We organize debtors across the country and in Maryland to transform individual financial burdens into collective power in the fight for debt cancellation and universal public goods, including healthcare. And I will pass it to my colleague, Sam, who's also on this call.
Good morning, everybody. My name's Sam Winans, and I'm a medical debt organizer working out of Baltimore for the Debt Collective.
Great. Awesome. Thank you. And so today, like Jenny said, we're going to be talking about medical debt, which is an issue that's touched many of our lives in different ways, whether that's through personal experience, seeing a loved one struggle to afford an unexpected bill, assisting community members in navigating this hardship. Today, we want to give an overview of the impact of medical debt on nationally and locally, share exciting reforms in Maryland's legal landscape that have been achieved by advocates, especially through End Medical Debt Maryland, which is an incredible coalition that we're all members of and that we'll talk about later, the gaps that still exist in the landscape, and the next steps to strengthening protections from our perspective. And then one last thing, one last housekeeping matter before we start. For this presentation, we're going to be using the word patients to describe individuals who have lived experience with medical debt. This is a topic that I think is still up for debate on what the right language is to use to describe people experiencing medical debt. So we've seen in this area the word patient used, but also healthcare consumer. For us, the word consumer implies that the individual has a choice. And that's shaped by a lot of by many factors that restrict people's ability to make an informed economic decision. So seeking and receiving healthcare has different impacts and consequences than a typical consumer choice that you would see. It can be life or death. There's also economic constraints. There's a level of consent and decision-making ability in moments of healthcare crisis. There's language barriers. And so with medical debt, we from our perspective and from the community members that we've worked with who've shared their stories on what the experience of medical debt is like, it really stems from a power imbalance between both healthcare recipients and the industry. So we feel that the word consumer kind of obscures that imbalance, and that it suggests that patients have equal power in this area, and can make an informed decision when we do see, people are in crisis, when they're seeking healthcare services, when they're accruing medical debt. That's not really a choice. So I'm just setting that out to say that that's why we're using the word patient in this context, but we'll want to hear from you at the end of the presentation on which language you prefer. So that said, I am going to pass things, we can move to the next slide, and I'm going to pass things to Lindsey to kick us off on the medical debt crisis and laying that landscape.
Thanks, Ashley. I want to start us off just by setting up the scale of the problem. And before getting into some of the numbers on these slides, want to underscore two additional points for us to keep in mind as we're going through this presentation, and as we're also thinking about questions and answers for the end of our presentation, a kind of discussion. And one is that medical debt is a symptom of the way that our healthcare system is structured and financed, rather than something that can be addressed in a total vacuum or in total isolation. And something that I know that both the Debt Collective and Public Justice Center have spent a lot of time thinking about and working on is how to find structural interventions that address these structural problems, and recognizing the ways that these problems are situated within these broader systemic circumstances that Ashley was just sort of starting to get at. And I also want to emphasize the importance of thinking about, for this reason, legal and policy interventions that don't place the onus on the patient in order to seek their relief from debt, in order to be able to secure healthcare access, but really recognize also that we have a number of tremendously powerful institutions at the core of our healthcare system, and that there are certain rules, guidelines, and laws in place around institutional accountability that we can lean on, rather than relying on patients to sort of be their own self-advocates, as I'm sure so many of us who have experienced the healthcare system or have worked with people who have been subject to some of its abuses know. Many people have to. And so the medical debt crisis can be somewhat difficult to quantify because so much medical debt, the vast majority of it, is held by these private creditors. But there are still a lot of attempts to do so, and some really interesting ones that I think have produced data that we can look to sort of begin to get a grasp on the issue. Recent estimates place the amount of medical debt in collections alone in the US in the range of $88 to $140 billion. But what's really important here is that with these numbers, and most of the time when you come across statistics that are estimating the amount of medical debt in the country, what you're actually looking at is the amount of outstanding medical debt that's been sent to debt collectors and formally reported to the major credit reporting agencies, that's Equifax, Experian, TransUnion, and is still on people's credit reports, because this is how these numbers that try to aggregate the total amount tend to be gathered. And so what's the problem with this approach? Well, it means that these numbers are actually dramatic undercounts because of the constraints that this data that they're using is subject to. It means that they exclude many billions of dollars of medical debt that people are carrying on credit cards, in the form of personal loans from family and friends, if they're lucky, and often in much more predatory loan structures. A lot of us here will be familiar with payday loans, but it can also be high interest rate payment plans. There are all kinds of ways that people finance medical debt that doesn't appear on credit reports, in ways that get captured with these 88 to 140 billion sort of, the estimates tend to hover closer to 140 billion to 200 billion. And they also exclude a lot of medical debt that that is held by healthcare providers, often hospitals, as we'll get into, who send patients to collections and really squeeze them in the collections process, and often through more extreme collections actions, without necessarily notifying credit agencies. And so as we were thinking about what the actual scale of the problem is, and this is something too, which we'll discuss, becomes quite clear when, as our organizations have done, you start to talk with people in different communities that are disproportionately impacted. It's better, I think, to look at some of the more recent attempts to try to grasp the entire scale of the issue. And so last year, there was a really ambitious survey conducted by the Kaiser Family Foundation that tried to account for all of these different forms of medical debt that don't appear in the credit reporting agency data. And it's good to get in the practice of doing these surveys because, as some folks here might have seen, the Consumer Financial Protection Bureau is attempting to they're beginning a rulemaking process. And the idea is that they'll be trying to remove as much medical debt as possible from credit reports. Which of course doesn't mean that the problem is disappearing. It doesn't mean that people aren't continuing to be subject to collections harassment, to threats of lawsuits, and to the various consequences that spiral out of these collections and billing practices. But what the Kaiser Family Foundation survey found is that more than 100 million Americans are struggling with medical debt. I mean, this is an enormous number that may surprise some people on this call, and unfortunately also will not surprise many people on this call. It's about 40% of adults in the country. And we can anticipate too that these numbers are going to continue to grow, especially with the millions of people who have been kicked off of Medicaid with the end of the public health emergency this year, and with the steady trajectory of healthcare costs continuing to rise. And so just, I think some level setting with these points is useful for us all to be on the same page. Next slide, please. And so now that we have a sense of the scope of the problem or the scale of the problem, I think it's important that we also think about who's impacted. And the short answer here, because we just looked at these numbers, of course, is that everyone to some extent, except people who are extraordinarily wealthy, but critically, some people much more than others. The burden of medical debt is not evenly distributed. It reproduces existing social and economic inequalities. And the consequences, of course, are especially devastating for the same demographics of people that face so many economic and social consequences in the United States. Like other types of medical debt, like other types of household debt, medical debt is extremely racialized, and Black adults and also Hispanic or Latino adults are the most intensely affected, even when you control for these other social determinants of health that traditionally people think of as sort of like padding people's economic situations, like level of education, total assets, and similar points. And I want to draw everyone's attention to these numbers just because I think they're useful to sort of like situate the problem in our minds, that 56% of Black adults in the US, as part of this Kaiser Family Foundation survey, 50% of Hispanic or Latino adults owe money for medical or a dental bill actively, currently, at the time of the survey, which, as I said, was pretty far-reaching and tried to account for a lot of different data points. And that's compared to 37% of white adults, which of course is a still extraordinarily high number that should alarm any of us who are concerned about healthcare access and provision, but of course dramatically different from these other numbers that we're looking at. 48% of women owe medical or dental debt compared to 34% of men. And I think a lot of folks who've spent time recently with someone close to them who's given birth may have some inkling of part of why this is. I mean, the amount of debt that women tend to accrue in the process of giving birth is something that's been flagged in various reports. And the way that this also then becomes a gendered issue is really important to acknowledge. And then nearly 80% of medical debt in collections. So this is thinking in terms of like that debt that does appear that has been kind of like pursued with increasingly aggressive means, belongs to people in low-income households with zero or negative net worth, right? So these are people who literally do not have the money to pay for this debt. It's not tucked away somewhere. It's people who have nothing that they can have extracted from them in the way of payment for healthcare that they need. And some other populations that don't appear on this slide, just because the data is more like nuanced, and I wanted to keep the numbers here streamlined. Disabled people or people identifying as disabled are far more likely to have medical debt. That won't surprise anyone. And veterans are as well, which is interesting to think about in terms of the limitations of our services for veterans, and the fact that a lot of people think of veteran healthcare as being very strong. Next slide. And so again, I think underscoring the social and economic impacts and the ways that these impacts are really uneven and they cut across different areas of people's lives is really critical. As we said, medical debt reproduces existing social and economic inequalities, which means that it traps people in these cycles of poverty and economic insecurity that are really difficult to escape from, as anyone who's been there or worked closely with people in various contexts who will know. 30% of Americans report having had to choose between paying for medical bills or basic necessities. And when we talk about basic necessities, we're not talking about the things that are sort of derisively invoked to justify restricting social services. You know, people are getting new jet skis. We're talking about things like food, heat, and housing. And then some data that Sam actually had flagged that I think is really useful as we're thinking about the intersectionality of healthcare, of housing security, is that a quarter of lower income adults, Black adults and Hispanic or Latino adults, approximately a quarter of each of those populations that report having medical debt also report having had to change their housing situation because of that debt. Which is, when you think about what that means for such a consistent percentage of the population across these different demographic areas, medical debt is a real destabilizing force in every sense of the word, and shapes people's lives beyond just the way that they think about healthcare. And of course, as I think some folks here have spent time thinking about, because of high interest rates, people who are already struggling economically end up ultimately paying more on medical debt over time than the more financially secure, who are able to pay off bills from the start or don't accrue that debt in an ongoing way. And so in some sense, medical debt, like many other types of debt, is like a regressive tax. Next slide. And all of this has huge public health implications that I think are especially salient in light of the fact that we are, are just coming out of the really throes of the COVID-19 pandemic. I'm choosing my words carefully because I know that there's a lot of conversation about whether the pandemic is truly over, and I want to be cautious about not flattening that debate. But I think with attention to questions of public health and the ways that everyone's health is tied up with those of others in moments of public health emergencies like COVID, and also, on a more general year-to-year basis, it's really important for us to think not only about the way that medical debt impacts people's lives, but the way that the threat of medical debt alone has a sort of punitive function. It's enough to keep many people from seeking healthcare that they really need. And so if you look at this graph here on the right, this is just the charting of a Gallup poll that is done every year, where for the last 20 years, or just over 20 years, people are asked whether in the last 12 months they or a family member have put off any sort of medical treatment because of concerns about the cost that they would have to pay. And this number has been sort of steadily growing. And over the last few years, there's been a real jump. And that means that 40% of people in the most recent poll that Gallup conducted that asked this question said yes, that they had postponed care, or a close family member had postponed care because of concerns about the cost. And respondents in another survey, as I flagged here, report fearing unexpected medical bills more than becoming seriously ill. So thinking about the way that even for people who haven't accrued medical debt already, the often encounters with seeing people that they love find themselves in these debt traps is enough to dissuade them from seeking care. It means that problems that are really quite treatable end up often spiraling into medical crises, which of course then end up being more expensive. And of course, it means that people are more likely in moments of public health emergencies to end up getting sick, and in the case of COVID, risk getting other people sick. I mean, this is really important when we're thinking about healthcare as a kind of collective issue. Next slide. And I do also just want to flag, as we're moving on from that slide, the way that as we're thinking about the fear of medical debt, the role that shame too plays, and the shame that people feel about having accrued debt. I mean, this is a common theme in any type of outreach that we've done. People have been taught their whole lives, that it's not moral to not pay your debts. But when they find themselves in situations where they literally can't, for the reasons that we just went over, they just devolve into this state of kind of like guilt and self-blame that really, I think, is incredibly devastating to any of us who know how the healthcare system has been structured in order to kind of like produce these debt situations. And to that point, thinking about institutional accountability is something that's really important as we're thinking about medical debt, rather than framing the question of medical debt as an individual choice. And I think anything that affects this percentage of the population is clearly not an individual choice. And so as we're launching into Ashley's breakdown of some different legal and regulatory changes that have taken place in recent years and that are slowly taking effect and that we're sort of keeping an eye on enforcement around, I want to flag the institutional accountability of nonprofit hospitals in particular. And most adults in the US who have past due medical debt owe money to hospitals. And the majority of hospitals in the country and all of the private hospitals in Maryland, so all non-state hospitals, are nonprofits. And these hospitals are private institutions, but they receive massive tax breaks and other forms of public subsidy in exchange for providing community benefits and something called financial assistance, or sometimes it's called charity care, to low-income patients. But the catch here is that this financial assistance is usually extremely difficult to access for the patients who need it most and who qualify. And this is what a lot of these reforms have attempted to address. It's one of the clearest places for intervention within a very complicated healthcare system, because there is this institutional responsibility that nonprofit hospitals have, and therefore every private hospital in Maryland has, which is where the vast majority of Marylanders seek care. And I'll pass it over to you now, Ashley, to walk us through some of the work that our organizations and many others on this call have been involved with over the recent years to try to hold these institutions accountable and address this kind of growing national and state crisis.
Thank you, Lindsey. So I'm going to talk about some legal reforms that are happening in Maryland that are really exciting and have been achieved by medical debt advocates, especially in Medical Debt Maryland, which, as I said earlier, is a coalition that we're all part of. And I see many of the members of the coalition on this call as well. I'm very excited to see you here. Definitely put your organization's name in the chat if you're part of the group, so that we can show how strong we are in numbers. But so first, I just want to give a quick overview of what the coalition is. Next slide. Okay. So, End Medical Debt Maryland, it's a statewide coalition. We're nearly 70 organizations and community members, and we're all working together to try to pass comprehensive medical billing reform and educate Marylanders on their rights as patients and eliminate barriers to health care. Many of the reforms that I'm going to talk about were originated within the coalition, as in the coalition, had the idea, drafted legislation, and then put that forward and got it over the finish line. Next slide. So, like I said, what I'm going to do is I'll talk about some of the new protections that have been put into place in the last few years. We'll also talk about protections that we're aspiring for but don't exist yet. And then some areas that we're flagging as needing special attention to ensure that the legal protections that we have in place now are actually being enforced. Right. Next slide. Okay. So the first one we'll touch on is short version. This is the hospital financial assistance law. So what this did in 2020 was it increased the household income threshold that in which hospitals have to provide free medically necessary care to patients to 200% of the federal poverty level. It also requires hospitals to offer patients a way to appeal denial of free or reduced cost care as part of financial assistance policies. We've seen, prior to this, and I would say even after this a bit, times where hospitals didn't notify patients of even the availability of financial assistance, leaving individuals unable to afford care and not sure how they were going to do that. It also prohibits hospitals from using a patient's citizenship or immigration status as an eligibility requirement for financial assistance. And finally, and there's some other parts to this law. These are just the pieces that we're highlighting of it. It requires hospitals to offer their written financial assistance policies in any language that's spoken by at least 5% of the population in the city or county where they're based. So those language access protections are really essential to ensure that patients with limited English proficiency are aware of their rights for financial assistance and are actually able to complete those applications and receive the assistance that they need. Next slide. All right. So the next one I'll just briefly talk about is a 2021 law, the Medical Debt Protection Act. So this was a really groundbreaking landmark law in Maryland. It actually positioned Maryland to have the strongest medical debt protections in the country and really was spearheaded by End Medical Debt Maryland. There's a lot of strong protections in this law. I'm just going to cover some highlights of it and then add a little bit more context to it. But first, it prohibits hospitals from placing a lien against a patient's primary residence. Also prohibits them from garnishing wages if the patient is eligible for free care. That's an issue that even at PJC that we've seen in our clients experience who we're representing in issues outside of medical debt. But so for example, workers' rights, where our clients have mentioned to us that they've had their wages garnished for medical debts. It also prohibits arrest warrants and body attachment against patients for medical debt. That was something that was, from our understanding, very rarely used in Maryland, but was still on our books until this law was passed. And it also prohibits hospitals from charging interest or fees on debts on or after the date of service by a patient who's eligible for free care. And that's a huge deal because, when you already cannot afford to pay an unexpected healthcare expense, that interest building and accruing makes it even harder for people to dig their way out of that situation. It requires hospitals to annually report to HSCRC, the Health Services Cost Review Commission, highlights of their key aspects of their debt collection activity, which creates a level of transparency in medical debt collection that we did not have in Maryland prior to this law. It also increases the time frame after an initial bill that a patient receives in which they can qualify for free or reduced cost care to 240 days. And that's so important because, there are times where person exits the hospital, they receive their bill, and we didn't want to have situations in which they're now outside of the time frame in which they could actually receive assistance with that bill. That would be a horribly inequitable situation. And so I'm just going to add to this that this law also included protections, estate protections, to preserve intergenerational wealth transfer. So specifically, hospitals are prohibited from making a claim. This is a little bit complicated, so bear with me. What we originally wanted was that there would be no ability for hospitals to take the estate of a deceased patient, so that we could completely preserve intergenerational wealth transfer. What we ultimately accomplished there was that hospitals are prohibited from making a claim against the estate of a deceased patient for a debt if the patient was known by the hospital to be eligible for free care, or if the value of the estate after tax obligations have been fulfilled is less than half of the value of the debt owed. That is very complex and not exactly what we wanted. And that's an area of the law that I think in future years we would love to strengthen, to just ensure that that intergenerational wealth transfer is just completely protected for patients. It also requires some reporting by HSCRC on the number of lawsuits filed by hospitals, by race and ethnicity, gender, and zip code. And it also requires HSCRC to develop guidelines for income-based repayment plans to be implemented by hospitals across the state. Next slide. So I'm just going to touch briefly on the HSCRC guidelines on income-based repayment plans. So under those, Maryland hospitals have to make payment plans available as an option to all patients. They can't require a patient to make a monthly payment that exceeds 5% of their gross monthly income, which is very important. As Lindsey pointed out, there have been many situations in which hospitals have been squeezing patients to pay as much as they felt that they could possibly pay. And so it's important to have that cap that can't be exceeded, and put people in a situation where they can't afford necessities in their life. They also can't charge interest on medical debt that's owed under a payment plan for patients who qualify for free or reduced cost care, so charity care. They can't charge interest on medical debts that are owed by uninsured patients or self-pay patients under those payment plans. And finally, for others, they can't charge interest until 180 days after the due date of the first installment payment. All of these protections that I've described so far have created sort of a system in Maryland, a safety net to ensure that patients do not fall through the cracks when it comes to medical debt collection, and that they have strong rights. But like I said, there's further that we can go with this. Next slide. So I'm going to talk about a two-part law. So End Medical Debt Maryland and other medical debt advocates fought for this over the last 2 years and have been successful. So this is the patient medical bill reimbursement law. And so what this is in 2021, HSCRC published a study that found that about 60% of patients who were eligible for free hospital care were instead wrongly pursued by hospitals to the tune of $120 million over 2 years, and they paid their bills. So what this law does is a 2022 law required HSCRC and several other state agencies to work together to develop a process for identifying, notifying, and offering reimbursement to those patients who paid their hospital bills but may have qualified for free care between 2017 and 2021. The follow-up legislation to this, which I would call a technical fix legislation, in 2023 further fleshed out that process for patients to receive refunds from hospitals. It also allowed for data sharing between state agencies to identify and refund patients while protecting their privacy. And it provided support to, or provides support to patients who were affected by this issue through the Office of the Attorney General to help them navigate this process. Next slide. And oh, Give me a second. Sorry, my screen went blank for a second. So I'm going to turn things over to Lindsey to talk about challenges and gaps in protections.
Thanks, Ashley. So despite these very hard fought and won protections that Ashley was just describing, there is still a long way to go. I mean, there are plenty of protections around medical debt and interventions that haven't even been attempted yet. And you know, that we hope that our coalition will be able to attempt alongside many other advocates and community members over time. And there are also areas that we've identified as needing special care when it comes to enforcement. And anyone who has spent time looking at the implementation of laws on this call will know that winning a bill or passing a bill is really kind of like just one stage of the challenges around ensuring that people are actually seeing its benefits, and that bills are only good as far as they're being enforced, which is really one of the challenges that we run into consistently, not just in healthcare laws that are meant to expand patient access and protection, but also in a lot of laws that are shaping the circumstances of people who are economically disenfranchised in the ways that we've talked about. They sort of get lost out, or they get left out of the process of monitoring implementation as advocates often move on to new fights. And so that's something that our coalition and our organizations have really been trying to ensure doesn't happen with these protections that we've won in recent years. And we're engaged in ongoing efforts to strengthen state medical debt protection laws through both administrative advocacy and ongoing legislative advocacy. And I think also the administrative advocacy is something that is sometimes overlooked as an avenue for really effective change that doesn't require organizations to go through the legislative process that has such a tendency to temper down the bills that are introduced through the amendments process, through kind of compromise with industry representatives and legislative opponents to economic interventions. And so some of the issues that we're running into or that we're seeing are industry exploitation of legal loopholes. And this isn't something that's unique to the hospital industry. I mean, this is something that happens across industries. I don't want to present this as something that's like a kind of like, there's someone in a room sort of like cackling and thinking about all the ways that these loopholes are going to be exploited. It's important, I think, to think about it as something that happens when you pass laws that aren't clear in terms of certain parameters, and that require industries to make economic concessions, in this case to patients. There are going to be efforts to interpret those laws in ways that give the industries the least painful process of recognizing them. And so there are limited enforcement, or there is limited enforcement that we're seeing of these existing laws for a number of reasons, one of which is a kind of vagueness around the penalties for violations. And in violations where there are clear penalties, they tend to be relatively limited penalties that some institutions might decide, in this case hospitals might decide, are just kind of worth, if they end up having to pay the fine, it won't be that much of an issue. And so one of the things that we've been doing as the Debt Collective, because it's so difficult to map the medical debt landscape for the reasons that we were describing earlier, is trying to actually go into various communities where we know there are disproportionately high levels of medical debt, and talk with people about their experiences with medical debt and whether they're struggling and whether they're being sent to collections. And this is not, I think a lot of people would describe it as not an especially efficient approach in terms of getting a ton of information very quickly. But when it comes to tracking legal implementation and enforcement, it's something that really produces, I think, a lot of a lot of useful, but also frustrating realizations. And so some of the issues that we're seeing with these financial assistance laws and patient protections that have been passed are institutions continuing to fail to notify patients of policies and treating the most passive possible notification processes, a kind of confusingly worded financial assistance application posted on the wall of an emergency room or posted in very fine print at the bottom of a bill as adherence to the law. And really kind of stretching what it means to make patients aware of financial assistance. We're also seeing patients who are being met with outright dismissal or misleading information when they inquire about financial assistance, being pushed toward payment plans rather than sort of given the application and having the process explained to them. There's a kind of obscuring of the path to actually receiving this aid. As a number of folks on this call know, there are routine application denials that happen across the board. These are extremely complicated applications in many cases, especially for people who don't necessarily have all of this documentation that's required for them ready at hand to work through the application process and then print out the application forms and submit them by mail. I mean, it's almost unnecessarily complicated. And David's gonna explain some interventions that we're trying to make at the level of the application itself. But even for people who manage to get over these hurdles of this unnecessarily complicated application process, we're seeing them be denied for reasons that are at best vague, and in many cases that are reasons that should not be grounds for denial. And I think a great instance here is people submitting applications that, because they may be undocumented, do not have the lines requesting a social security number or ITIN number filled out, and having those applications rejected as a result. And what I mean, I think many of us will find this pattern horrifying on its own terms. But in Maryland, among these other protections that we described, documentation status is not supposed to be used to affect people's eligibility for financial assistance. And so it's mapping these gaps in protections that exist alongside the gaps that we're already aware of. There are still, despite our coalition advocating very intensely for a ban on small sum under $1,000 lawsuits in 2021, and in 2020 advocating for all small claims lawsuits on medical debt to be banned, we still haven't passed that. It's worth noting, I think, also just as a point of interest, that hospitals appear to have temporarily shifted away from lawsuit practices, despite the fact that was removed from the bill in the legislative process. But because we haven't actually secured that as an ongoing legal protection, and because these protections, if you don't codify them, tend to slip away as soon as you stop paying attention, we really want to be sure to finally win that lawsuit ban, and to expand the protections around wage garnishments that Ashley was just describing as well, and other extraordinary collections practices. And so all of this is really an overwrought way of saying that even with these policies in place, even with these big wins, and this is not to discount those wins, but people with medical debt who should have received financial assistance continue not to be made aware of their eligibility and how their applications are properly denied. And I'm going to pass it over to you, David, to walk us a little bit through the process of intervening around the applications themselves, and ask our friends at Public Justice Center to, there you go, perfect.
Yeah, so as we've mentioned, one of the obstacles for people receiving the affordable care that they're entitled to is the complexity of the applications process. So as part of our efforts to enhance access to this affordable care, we've been given an opportunity to provide feedback on the Universal Financial Assistance Application, or UFAA. This is a form that's provided by the state of Maryland and offers a template for hospitals to use to build their applications on. A few of the hospitals have crafted their own applications from scratch, but 20 out of 24 financial assistance policies that we surveyed are directly using the UFAA or a lightly modified version of it. So any changes that we get to propose to the UFA will have far-reaching impacts. So it's a good opportunity for us. We'll talk a little bit more about our process for how we're doing that in a later slide. But our initial review of this process has revealed some troubling trends and some gaps. Despite the requirements that we mentioned to have these policies accessible in plain language and in the language spoken by at least 5% of the population, only 20 out of the 24 hospitals are actually facilitating that language access. A few hospitals still don't offer any translated documents or offer access to those documents embedded in other English language documents or buried on the website. And very troublingly, only 7 out of 24 of these application processes actually clearly state that free care is available. Some of these application processes are using clear language, like we provide free or discounted emergency and other medically necessary care. But a lot of these application processes are deliberately obscuring the availability of free care behind passive language or deliberately confusing language. Like a decision will be rendered based on the information provided as it compares with 250% of the poverty guidelines. It does not say anywhere in the application process that you are entitled to receive free or discounted care. So people's rights are not being clearly explained to them in these applications. And we know, because some of the hospitals are doing a good job of this, that it's it's a choice that they're making to obfuscate the availability of this care. The less charity care hospitals provide, the more of that money they get to keep in their pocket. Any of the unspent charity care funds remain with the hospital as revenue. So we are hoping to conduct focus groups with people who are impacted by medical debt or have experience applying for things in general to make these application processes as easily as possible. So if we're able to make changes to the UFAA, those changes will have a broad impact, since so many hospitals are modeling their application process on that. And I will say, I have a master's degree and training from a legal organization, and I've studied the law, and I found a lot of these documents to be incredibly confusing and difficult to parse. I found myself going back to the law and double checking my own understanding of it. So I can't imagine that somebody who is not trained or experienced in understanding these documents would be able to navigate this process without help. So hopefully there's a lot of improvements that we're going to be able to make there to make this process less intimidating and confusing for patients. Our plan, like I mentioned, our plan is to conduct focus groups across the state. We've already begun to schedule some, and I think I'm passing this off to Ashley to talk a little more about it.
Yeah, sure. Thank you. So yes, we're actually having a focus group later this month with our partners at Debt Collective to meet with behavioral health consumers who've navigated hospitals as patients for a variety of different reasons, to get their feedback on the UFAA and how to make these applications as easy as in plain language for people to fill out. So I'm going to talk more about how we're trying to strengthen protections, but I do want to highlight something that David said that's incredibly important, and that's that even though we have something like a uniform application, the processes and procedures that hospitals use are so challenging to navigate and are so different depending on the hospital that you're going to. Ideally, in Maryland and across the country, it would be that if a patient or soon-to-be patient comes to a hospital, they should be able to have confidence and peace of mind in knowing that the hospital that they're at, the process, what they're entitled to, how they access financial assistance, how their application will be treated, what criteria is used, is the exact same as a hospital a county over or a county over from that. And that's just not the landscape that we have right now. So the work that we're doing, we're also, the laws that I talked about before, the new laws that have passed in Maryland, we're tracking both implementation and enforcement of those laws to make sure that hospitals are living up to their obligations to provide charity care, but also that these reporting requirements are happening and that there's transparency and accountability in the system. As David was describing, we're working with people who, and working on trying to identify more people who have experience with medical debt, to bring them into the advocacy work that's happening and try to build power in communities that have been deeply impacted by these issues. Because what we've found is over the years, there have been very few forums that, number one, that they've been able to access and have a voice in. And number two, where their voices have actually been heard. And we want to change that. So we're doing that through direct outreach, community listening sessions, and know your rights trainings. And then finally, as members of End Medical Debt Maryland, we're all working together on strategizing for what's next in 2024. There's, as you've heard, a lot of changes that could be made to Maryland's healthcare system and to the way that patients experience the delivery of healthcare and the experience of navigating financial assistance that we can advocate for. And so once we're ready to reveal what that agenda is, we're happy to provide updates to folks on how we're pursuing that in 2024 and beyond, and would love everyone's support in the work that we're doing. Okay. Next slide. All right. So that was our presentation, and I hope that folks enjoyed it. What we're going to do from here is jump into Q&A, because we definitely want to hear from the folks who are on the line. We would love to hear first, for our first discussion question, we'd love to hear from you, your thoughts on what language you prefer to use in this issue area. Do you prefer patient? Do you prefer healthcare consumer? And we'd love to hear why. We'd also love to hear what surprised you and stuck with you in this presentation. What questions do you have for us? Are there any recommendations you have on how we can further this advocacy? So I will stop there and open it up to folks to talk to us.
Hi, this is Dan. I'm the Development Associate for Public Justice Center, and I will be reading the questions in the chat for our presenters to respond to. Our first question is from Liz Tung. Do some hospitals use presumptive eligibility instead of or in addition to the financial assistance application? Are there some best practices around that?
David, you wanna take the first stab?
Yeah. So for a little bit of background, one of the things that qualifies you for financial aid, if you qualify for a number of different means-tested programs like SNAP benefits, if anybody in your household gets free lunch at school, a number of programs, if you're eligible for those, you're automatically eligible for free or reduced cost care. And that should give you an opportunity to bypass the application process. A small number of hospitals do use a pre-verification checklist or have an alternative application to sort of streamline the process, but the majority do not. In addition, they don't even make the availability of free care, known in the first place, let alone all these qualifying factors. So that is one of our initial recommendations for this process, is that each application should have a pre-verification checklist to bypass some of the paperwork as possible. Although we do want to balance that against unnecessarily lengthening or making the application more complex. Some hospitals have added several pages worth of information and checklists to their applications. There's very little uniformity in what type of information is gathered in these applications. Some ask for 6 months of pay stubs from everybody in the household. There's just a wide variety of information collected. So we do want to include pre-verification in this application and better standardize what data is collected from people.
Yeah, and I want to underscore everything that David said, and And also just say that, I mean, a stronger presumptive eligibility framework for financial assistance has actually been one of our areas of focus at the Debt Collective nationally, because this process of having to demonstrate your need, as David was saying, involves such an arduous set of information gathering, document gathering. I mean, and I think something that we hear anecdotally from a lot of patients and debtors is that it's something too where they feel like the more documents that they're being asked to gather, the less likely they are to complete the application, both because of the time that it takes, but also because they feel like, oh, am I overstepping what I'm eligible for? These are people who are clearly eligible for aid, who financial assistance as a concept is designed for. And I think in general, our position organizationally is that a lot of means testing efforts end up excluding the very people that they purport to be protecting. And so that's a sort of bigger debate that can be had. But as David was saying, a few places do have presumptive eligibility questions, which take the form of asking about different means tested programs that patients might already enrolled in the financial assistance application process. I think one of the things that we really want to move toward is having these screeners be done far before we get to the point where a patient is filling out a financial assistance application. Again, because the process of filling out and submitting an application requires people to first of all, track down the application, know it exists. It requires them to print the application. It's very confusing, even for those of us who work full-time on policy on this and similar healthcare issues, to make sense of what hospitals are asking for, and they reject things in a way that does not reflect that level of confusion. And so what we want to do is really move the screener for presumptive eligibility far up in the process. And there are various forms that this could take that we're exploring. I mean, one would be as soon as a patient is able to give consent for treatment in other ways, recognizing that a lot of people who do enter the hospital are not in a position to fill out any documents, but they would be asked a very basic screener about certain programs that they might be enrolled in. If they are enrolled in a program that clearly means that they've already had their income verified by the state to qualify, then just immediately enrolling them in financial assistance and removing that entire process of people getting the stressful bills accumulating, the threat of collections accumulating, and having to kind of count on people being able not only to be aware that they have this potential relief avenue, but to push through all of the obstacles to pursuing it. And just before we move on to the next question, I also want to note that we're trying to figure out exactly to what extent this type of software is being used in Maryland hospitals currently, but we know that a lot of hospitals already use software. One of the most visible types of this software is owned by Experian Health, which there's a whole other debate to be had there about the value of having credit agency software being used by hospitals to check on patients' propensity to pay before they are treated. But the reality is that a lot of hospitals nationally are already using that software, but not using it to automatically enroll these patients in financial assistance or implement additional outreach efforts in relation to those patients who for whatever reason, the software has flagged as likely to struggle with the payment process. There are some hospitals where this software is being used to good ends nationally. Again, this is, we don't know whether we want to really kind of push for a type of intervention that enriches these credit reporting agencies, but it's something for us to keep in mind that many hospitals have some read on a patient's eligibility from the start. And the question is how they're choosing or not choosing to use that information to enroll them. And so I think Public Justice Center and Debt Collective are both really interested in exploring these questions and exploring the presumptive eligibility framework as a way of really a meaningful intervention. And would love, I'm sure I can say on both of our behalfs, to talk with anyone who's interested in talking more about this together.
Yes, thank you so much, David and Lindsay, for giving that really comprehensive answer so that we can, you know, explain just how important presumptive eligibility is. I did want to just this morning, we're going to try to use Zoom to its fullest extent with its features and launch a poll. So we have a poll for you guys for that question that I pointed out earlier about what language do you use, do you prefer to use to describe individuals with lived experience with medical debt? Let us know if you can't see it on your screen. It should have just popped up. But if you can't see it, please let us know. And you could always type your answer in the chat as well. But which do you prefer to use? Patient, healthcare consumers, or is there other language? And feel free to come off mute to let us know, which one you use and why. We'd love to hear from you. And then once we're done with that poll, we can definitely share where we land on this as a group. And in the meantime, as people are filling that out and thinking about, oh, that's great. Okay, so we've got our poll results now. So we've got 82% of folks prefer to use patient, we've got 12% prefer to use healthcare consumers, and 6% prefer to use other language. So we'd love to hear from people on why you chose these different options. And as we're waiting for folks to share that, or you can also put your answers in the chat, we can move to the next questions that we have in the chat too.
Okay. The next one comes from Suzanne Schlattman from Maryland Healthcare for All. It says the state is now starting to consider the parameters for the next all-payer waiver agreement with CMS. Are there potential opportunities for incorporating stronger protections and enforcement of these protections in that process?
That's a great question. I'll take a stab at that, but I also any of our partners that are on the line too, if you'd like to weigh in, that would be great too. So thank you for sharing this information. I know, as advocates and also as a coalition, we're always looking for opportunities to strengthen protections, not just through legislative work, but also through administrative advocacy when those opportunities arise. Obviously, with legislative work, we're waiting until the next year to be able to have a very short period of time, 90 days, to push something through, and relying on lawmakers to both, be well informed on the issue and make the decisions that we feel are in the best interest of and are informed by people with lived experience with medical debt. With administrative advocacy, that's a year-round forum that is definitely more accessible to people with lived experience. So I would say I think that there are opportunities there. What exactly those opportunities are, I'm not sure yet. That's something that we need to explore to see if there's ways to build that into the next waiver agreement. But I think these things on presumptive eligibility, on some of the gaps we've seen in the system, one thing that we didn't touch on today is that some of the processes that hospitals use, some use asset and geographic tests to decide whether or not to provide financial assistance to patients. And so that's something I think could be eliminated across the board, from the perspective of medical debt advocates. So I'm going to stop talking there and let my partners speak as well if you guys have any thoughts on this.
Yeah, I mean, I don't have a kind of like perfectly thought through answer, but I agree with Ashley that this is a really great question, and I would love to think about it with whoever posed the Suzanne, and also with anyone else who might be interested. I wanted to check in the chat to see who posed the question. But I think, I mean, one of the things that was actually flagged by a really excellent report that's, I mean, continues nationally to be one of the best explorations of this issue at the level of data produced by National Nurses United, who I believe we actually have a representative from our partner Corey in the coalition here today. A few years ago, noted that, and I don't know if this will extend to the terms of the waiver, but noted that because of the all-payer system and because of the way that this unique Maryland system is structured, there's actually a kind of pool of funds that hospitals across the state collectively contribute to, and that public money is also used to build out, that offsets the cost, or beyond the kind of tax exemptions, which are already, you know, extraordinarily valuable to hospitals, of providing financial assistance. And I think one of the things that became clear over the course of this research and through this report is that money, there are no requirements that money that's put into a pool to be used to offset the cost of providing financial assistance actually be used to that purpose. And one of the most, I think, damning statistics from that report was the finding that the value of those funds that went unaccounted for from that pool, and the value of medical debts that were pursued by Maryland hospitals through lawsuits against patients were almost exactly the same over a particular period of time. And so just thinking about the waiver and CMS and interventions around that, I think it would be great to think about making sure that money actually has to be used to support patient care, rather than sort of, you know, being there but then disappearing mostly untracked through the hospital financing system. Yeah, thank you for the question.
Next question comes from Sarah Coffey Bowes from Civil Justice. Has there been any discussion effort to create a centralized qualification system for financial assistance? Essentially, hospitals would no longer have the ability to decide who does and doesn't qualify for charity care, and there could be a state-run qualification system.
Oh, I would love to see that. That would be incredible. I think that and Medical Debt Maryland, in, you know, over the years, and other medical debt advocates as well over the years, have kind of tried to tackle pieces of that through legislation, and also through being part of things like the work groups that HSCRC has convened on financial assistance, to try to create that sort of uniformity across the system. It's hard. This advocacy, I think, has not, you know, obviously it hasn't been easy, and it's not we've, you know, the Medical Debt Protection Act really was sweeping reform, but even that had some gaps in it, in areas that we fought really hard to accomplish that didn't quite make it into the final bill and the law as we see it now. And so I think what you're kind of talking about could be like a Medical Debt Protection Act Part 2. And so I guess to answer your question, I'm not sure if there's been a formal discussion on doing that, on having sort of that uniform system on the legislative or state, or like through legislation or through administrative forums. But I do know that that's something that the coalition, I think, would love to see, is that uniformity and that strength, where no matter what hospital you go to, your experience in terms of accessing financial assistance and being determined whether or not you're eligible for it is the same. And any of my other partners who are on the line, if you'd like to take a stab at that as well.
Yeah, I will say, you know, the hospitals are given a lot of leeway in how they implement this process, as we've seen. The UFAA is just a base that they can build on or disregard entirely. And as we've seen, the majority of hospitals are not using that leeway to make the process easier or better. but it could go either way. Of the 4 hospitals that don't use the UFAA at all and came up with their custom application, that includes one of the best and clearest and most helpful application processes, and also the worst that I surveyed, that is the most burdensome in terms of information collected. So I will say that the freedom that's been given to hospitals to implement this process in their own way has not been used to the benefit of patients predominantly. We're hopeful that we can make some adjustments to the UFAA if we put, for example, the requirements for free care and make that clearly stated in the universal form. Then hospitals are going to have to make a conscious and deliberate and obvious choice to remove that information if it's included in the base application. So there are some things that we can do in our existing process and opportunities to smooth things over. But overall, I think there's a great need for the imposition of some uniformity and to make these applications a little more similar across the board.
Yeah, and I'll just jump in and keep it quick. I appreciate this question, Sarah, and love this idea. I mean, just thinking about the way that these, with problems like this, I think setting up structures that kind of like preempt the problems that we're seeing is the best approach, right? Removing the kind of competing incentives and competing motives that appear when what you're talking about is like private institutions with their own kind of economic interest in ensuring that, frankly, this is like me speaking from my position and our organizational position, but that have a certain type of interest in ensuring that patients don't get too comfortable expecting healthcare that they can't pay for. That's kind of built into the way that our system currently operates. And I think that by setting up a public infrastructure that would have both these determinations and application processes centralized and could, I'm sure that there would be all kinds of issues that would be presented about data sharing, but as I just shared, we have these credit reporting agencies that are selling software that are sharing extremely personal data to institutions with far less accountability than public institutions. I think that it's always behooves us not to get too bogged down in bad faith arguments around those objections. But I think that would be an excellent way to avoid this situation where we're kind of, trying to track these different processes and trying to do so by talking with people who, of course, whose experiences are not, that can't easily be said, like, if because one person had this experience, everyone does. Let's just like remove all of that that uncertainty and lack of clarity and like push for a centralized system like this. And I think, I'm sure it would be something that would be met with many objections, but I think it's a great thing to set as a kind of like goal and try to work toward that, even as we're like trying to intervene in these other ways along the way.
Yes, and I do, before we jump to the next question, I just wanted to flag Patty, our partner friend, ally from Progressive Maryland's response to the patient versus healthcare consumer versus other, that her organization, they like to use the word patients or people in need of care, people seeking care, and wanted to say that language like patients' rights and patients over profits expresses our values and who and what we want to center in all the various conversations / debates about healthcare policy. Thank you so much for sharing your perspective on this.
The next question we have comes from Elizabeth Green. It says, will you please issue social credit or dollars or other credit to pay people who complete surveys so that you set an example for healthcare providers?
Yeah, do you, so I think I understand the question. So I'm assuming this is compensating people with lived experience in these issues for the time that they take to provide feedback and to be part of this advocacy, which I totally agree with. Actually, PJC is an organization, that's something that internally we're exploring how to do that across all of our work. We have done that through many of our projects with community members that have worked with us on achieving not just achieving, but fighting for systemic changes, both through legislative advocacy, through public campaigns, and through other work in sharing their story, because that time and experience and, displaying that sort of vulnerability in sharing your story to help further a cause should be compensated. And so that's something that we have been discussing with our partners to figure out, how do we do that? There's a lot of people experiencing medical debt, and a lot of people who I think have incredible stories to share about their experiences in the hospital system, especially with financial assistance. And so that is not off the table, and that is something that we're striving to do, and figuring out, what is the system to make sure that people are fairly and compensated for their time, but also that we're addressing barriers that they may experience to being able to even be involved in advocacy. So, for example, transportation, access to childcare, being able to safely take time off of work if they have to engage in this advocacy, if they don't have access to internet or to a computer to do things like submit testimony. How do we, as organizations with resources, fill in those gaps for community members so that they can effectively share their voice in these different arenas where so many important decisions are being made? And if any of my partners want to chime in on that as well. Okay, I see nodding heads. Okay. I think that means we can move to the next one.
Okay, we have a hand raised from, looks like Lauren Goodsmith has the next question.
Yes, thank you so much, Ashley, David, and Lindsey. Great presentation. And Ashley and David, thank you for the language access rights in medical care presentations that have been so valuable to our clients. It always amazes me how frequently it happens that the individuals we chiefly work with, mostly asylum seekers, uninsured, many of whom do not yet have legal work authorization, so have no income, they still have to go through sometimes the process of applying for and occasionally still being denied or getting follow-up pushback about getting free access of getting free or reduced cost care, especially say if they find they need to go to the ER for some reason. If we know they're going to the hospital or somewhere to seek care, we will often have someone accompany them. But if they go for urgent care and then afterwards we learn about it, it can be a whole process. I was wondering if incorporated into the language access rights sort of approach, there could also be for everyone training in advocating, basically saying, I have a right to learn about your free or reduced cost services. At the time, of course, if someone is there for an urgent issue, they're focusing on getting taken care of rather than the payment that comes. But it's so true that so many people, not only in our population, but in the ones that you've also been speaking of, under-resourced individuals, they will put off going for care for the things that they need because they are so afraid of those letters coming from the collection agencies. So just putting out there that just advocacy training for individuals who are likely to encounter this situation to be able to advocate for themselves, whether it means, learning the name of the some of the legislature you've mentioned, or basically just saying, I need to talk with your social worker or whoever manages the charity care. Thanks.
Yeah, thank you. So much for this question, Lauren. One of our organizational partners that we work closely with is CASA, and we've heard similar things from them and from their members about both all of the things that dissuade them from seeking care, and also concerns about the risk of, if they seek care and can't pay, be facing risks of deportation. There are all these different elements of coercion that people get worried about when they have insecure documentation status. But I think this idea, it's not something that I've spent a ton of time thinking about, aside from just making people aware through know your rights trainings, that these protections exist, but the actually helping them prepare for posing this question when they're seeking care is not specifically, I think, a really important framework that I organizationally we haven't been thinking about in those terms. And I can just share, I myself, a little over a month ago, had an extremely severe injury that has kept me, that landed me in multiple emergency rooms, going through all these different procedures. I have a ton of bills rolling in, and have spent a lot of time in hospitals in the aftermath. And what's so striking to me about this point that you're raising is that throughout this process, I've been trying to use it as an opportunity to sort of map the experience of trying to push for more information about financial assistance. And I'll just, anecdotally share that I have hit so many walls. I have been treated in ways that are, range from dismissive to hostile for pushing for just a basic form with a financial assistance policy, which hospitals are supposed to be able to provide in multiple places. And so thinking about, and most people aren't going to fight on this as hard as I am, where this is such a focus of my work. And so I really love that idea of not only making people aware of their rights, but helping them understand how to kind of self-advocate for them, knowing at what moment they can tap others in. But there's just an immediate barrier that people encounter that I've encountered, and that I've, the thought that I keep having is oh my God, if I wasn't really committed to pushing on this, I would have given up, the first time that I tried, and been well, I guess that just doesn't really apply to me. I guess that's just, a paper protection, but it's clearly something that's producing a negative response. So thank you for asking that.
Thank you. And Lindsey, thank you for sharing your personal experience as well. Like you were saying, you as someone who has this background knowledge on what to look for, what kinds of questions to ask, for folks who don't have that background knowledge, the system is incredibly difficult to navigate, and especially when you're navigating it in another language. And that should change. We need to change that. So we do have a few last questions in the chat that we'll try to tackle. For anyone that we don't get to, please feel free to follow up with us outside of this presentation. We're always looking for more partners to bring into this work, to bring into End Medical Debt Maryland, and into the fight. And so I do see a question in here from Liz. Do hospitals in Maryland sell medical debt to debt collection agencies? If yes, do any of the policies / protections passed require changes in those companies' practices? Lindsey, do you want to take a stab at that one?
Yeah, and I'll just, I know we're right at the end here, but this is an important question that has come up a number of times. And I just want to flag that Liz also added, also, this is slightly off topic, but is there any interest in adjusting COMAR regulations to enable groups like RIP Medical Debt to buy and write off larger amounts of medical debt in Maryland? So no, hospitals in Maryland are prohibited from selling medical debt to debt collections agencies. They can contract those agencies to pursue debts, but they cannot actually sell that debt. Which is a good thing. What it does mean is that these processes that have become increasingly popular of buying up medical debt and relieving it by groups like RIP Medical Debt and my own organization's Rolling Jubilee Project, which was a precursor to RIP Medical Debt. It does mean that we can't do that with medical debt in Maryland. I'm sure that some people have been thinking about this. I will say, from my own position and looking at all of the states where it is possible to buy debt on the secondary market, us organizationally would be extremely wary of changing the COMAR regulations to allow for this, because part of the initial impulse that produced this practice of buying medical debt and selling it was my own colleagues' attempt to draw attention to the absurdity of the secondary debt buying and selling market, and also the cruelty of it. And so I think once you open up the regulations and change them to allow for groups like RIP Medical Debt to buy and write off those debts, you're also opening up the regulations for predatory debt collectors to do that. And that will affect, I think, far more people in far more devastating ways, based on what we've seen, just patterns in other states over the years, than the debt relief measures will help. And so I think it's a good thing that this happens, but I think it's good for us to be cautious about opening that can of worms by returning to the regulations and risking actually limiting the protections for some immediate relief in a way that could have really negative consequences. Sorry for taking us over the time here. I'll pass it over to Dan and Ashley to wrap us up.
It's totally okay. And I appreciate you tackling those two questions. Thank you. And thank you to everyone that attended today. This has been an incredible discussion. More topics related to this that I didn't know that we'd get into, that has just been very informative. And I hope this has been a great discussion for everyone else who's been here as well. Please feel free to follow up with us after this presentation. We'd love to talk to you. We would love to collaborate with you on this work. And we'll share our contact information in the thank you that'll go out after this, and as well as some resources. Thank you again for coming. And I guess I'll pass it back to Janice to officially close us.
Yeah, I took notes during some of this. As a person who is a patient and or consumer and or seems to have to go to the doctor a lot. I don't know where the actual title for me is, but yeah, thank you so much to of course, our folks at PJC and the folks at the Debt Collective, and everybody that joined in and asked really probing and interesting questions about this issue. This is something that, we all, are going to have, as long as we're human and breathing, are probably going to have interactions with the healthcare system that's most in proximity to us. So this is great, very useful, very topical information. So I thank everybody for contributing to the conversation. Be on the lookout for the next Justice for Breakfast. Thanks to all our friends and partners for joining us today. And, again, follow up with the folks if you have additional questions or commentary about the presentation today. And we'll end it there. Thanks so much for coming.